Okay. So let's just see here. I see Grace and Perna and Neha and Uzo and Sergey, and is David here? Guess we're just waiting on David. We'll give it one more second and then we'll get going. And you see the screen that says EP conference where my arrow is that right?
You do.
Good. Okay. Okay. So this is a 10-year-old who comes into clinic with an irregular heartbeat. And why don't I ask Neha what you think is going on here?
Morning, Dr. Kravis.
Good morning, Neha.
Looks like sort of group beating. And I see P before every QRS, up in one in ABF, so it's sinus. And then there is prolongation of PR. And then a drop beat. So it looks like Wenke rocking, but with like sinus, seems to be more pronounced, the pauses.
Let's say that again. It seems to be what?
The Wenke, like the period of after the drop beat seems to be longer than I'm
Are
used
you
to
sure that the
seeing.
patient, are you sure it's all sinus? Neha?
Sorry, I was muted. I said, I think that there are P waves which are upright, it looks.
Well, let's look in lead V2. Do these P waves look the same as this P wave?
No, they don't.
What about in this lead here, V3?
No. So are these?
I agree that
short?
in leads 1 in AVF, it appears as if the axis of the P waves is similar, but I do think you could argue that this P wave here is a different morphology than this P wave. It's a subtle difference, but right, there's a little bit of a double hump here.
Right. So is it like an ectopic atrial focus beats, and then that P wave, which is dropped, maybe like a PA blocked PAC?
Sounds to me, Neha, like you're in the middle of Central Park, which may not be too far from the truth. The background noise. Right, so this is sinus rhythm with ectopic atrial rhythm. So you sort of have a sinus beat and then 2 ectopic atrial beats. And then there's a pause, presumably because the sinus node has been suppressed transiently by this ectopic focus. And then again, a sinus beat, and then here 3 ectopic foci, and then a pause, and then a sinus beat, and 2 ectopic foci, or actually 3, sinus beat, 3 beats. So this is essentially grouping of sinus followed by either atrial couplets or atrial triplets. So this patient has an ectopic atrial focus. So let me ask Sergey. So you're seeing this patient who was referred to you because the patient doesn't feel anything. but the pediatrician heard something, heard this irregularity and wanted it to be evaluated. So now you've done this EKG and you see this observation that the patient is having a lot of ectopic atrial beats. What would you do to evaluate this patient? She feels fine, she is asymptomatic. Her examination, other than an irregular heartbeat, is normal. What would you do?
Well, I guess I'll start with some kind of monitoring, meaning like a Zio patch or some kind of a Holter monitor.
Now, why is that? To look for what?
Well, I would want to know if this is a consistent finding or it just comes and goes. So
Okay.
how long does this patient stays in this ectopic arrhythmia?
Why does that matter?
Well, because although they are asymptomatic now, I guess if they continue to stay long enough in this rhythm, it might cause some cardiomyopathy, I guess. Or
Yeah,
maybe not.
if you were stuck in tachycardia all the time, you would sort of want to know that because it could cause tachycardia-induced cardiomyopathy. So I agree that some kind of extended monitor, whether it's a Holter or a Zio or a Barty or something of that nature, to see what is the tachycardia burden. What else would you? Any other evaluations you would do on this patient?
Well, we can jump to the EP study right away, but I guess you're asking about something in between.
Yeah, we wouldn't normally go straight to EP. So
Echo. We'll do
why
an
would
echo
why would we do an echo? I agree, but why?
to check if there's any thrombi.
Okay. Anything else you're looking for on the echo?
Well, I guess any changes in the right atrium.
Well, what kind of change? You wouldn't normally see any changes in the right atrium, would you? But you're looking for the function, right? Because you just said you're worried about the patient having a tachycardia-induced cardiomyopathy. Well, you could just do the Holter and see how much they have before you decide whether you want to do the expensive study of the echocardiogram. But if the patient is already in your office, you probably would want to do an echo to assess the heart function, right? And
Yes.
and so that's one of the so that's I often joke that the echocardiogram in this setting is sort of like the hemoglobin A1C for a diabetic. It's a good indirect marker of how much tachycardia a patient is having, or at least if their heart rate has been chronically at a very elevated rate. And so you would typically see not only dysfunction, but dilation of the ventricles, possibly the atria. In this particular case, the patient had normal heart function with normal dimensions of the heart. And okay, so let's say that you get this Holter back and it shows that she does this a fair amount of the time, the patient, but that the average heart rate in this 10-year-old is 99 beats per minute. Is there any other testing you would do? And then how would you manage this? Anything else you want to know about the patient? So one thing that could affect this is thyroid, right? So if you were hyperthyroid, that could conceivably affect this type of rhythm. So thyroid function studies had been done recently, and interestingly, they were normal. So the thyroid functions are normal. So now you have the whole history. The heart function is normal. There's not dilation. The average heart rate is elevated. It's about 100 beats per minute, but you have no dysfunction, and the patient is asymptomatic. So what are the options in terms of managing this?
I guess one option is just to monitor
Mm-hmm.
And do nothing except that. And the other one is to maybe try and rate control if they are tachycardic most of the time.
What's another option?
Ablation.
Yeah, you could ablate this patient. So, the indications to ablate in this patient or to treat this arrhythmia in some fashion, whether by ablation or medication, would be either if the patient were symptomatic, which the patient is not, or if there was dysfunction or dilation of the heart, which there is not. And so now some would argue that in an asymptomatic patient who is having this much tachycardia, there's a possibility that the patient could develop tachycardia-induced cardiomyopathy. So I think it's not unreasonable to consider ablating a patient like this because of concerns that it could develop into a cardiomyopathy. That said, it is also not unreasonable to watch it and perform, maybe every 3-month Holters or something like that, just to see what the burden of tachycardia is, follow the echocardiogram. The key is, if you're not going to intervene for this, you need to have very good follow-up. And then my last question, I guess I'll ask you, Sergey, is if you had to predict where is this focus coming from, what would you say?
Well, based on the morphology of the P waves, I would say that it's coming from somewhere near the sinus node, because it's positive in 1, it's positive in 3 in AVF.
That's correct. That's correct. So that would suggest that it's likely in the right atrium, not far from the sinus node. And so that would actually make me a little bit more interested in ablating it, because theoretically it'd be relatively easy to get to from a technical perspective. Some of these can be the most common location that ectopic atrial tachycardias arise from is the orifices of the pulmonary veins. But the next most common is in the right atrium, oftentimes near the right atrial appendage. So this looks like it could be maybe at the base of the appendage or near to that area. So any of those would be reasonable. In this particular case, the patient's family elected to continue to monitor this. And so we're going to repeat a tracing in a couple of months and see what follows.
And Dr. Paz, I'm sorry, if you were to treat medically,
yes,
we would do like the beta blockers. What would be your first line?
Well, why don't I ask you, Zoma, since you're going to be out on the front line very shortly?
I mean,
Short months.
I was thinking to go with beta blockers first, like propranolol would be my go-to.
Well, in a 10-year-old, you can use propranolol, but propranolol is a little challenging in a 10-year-old because it has to be given frequently, unless you give the extended release propranolol. But I don't usually like extended release, especially as a first line.
So I could do metoprolol then.
And you could use metoprolol or nadolol or atenolol. Okay, so oftentimes that does not work. So you do that and you get back the Holter and it doesn't look a lot better. So what would your next option be, Uzo?
Well, after I've maxed out my dose on whatever beta blocker I chose, then I guess I could move to amio. Seems like it's a big gun. I know we could use it, but I sort of don't want to jump right to that. But that would also be an option.
What would be the downside of amio?
The fact that I would be committing this patient to amio for something that amio has a number of side effects. I don't think I want to commit this patient to that.
Not a good long-term agent. Yeah. You use amio for short-term treatment, or alternatively, it's used in very old people in whom it doesn't matter. In other words, if you're 94 and you have an arrhythmia that can be well managed with amio, we don't care if you're going to get pulmonary fibrosis in 10 years. But if you are 10, you know, after 10 years, there's a very high chance the patient will develop pulmonary fibrosis. So amio is really a bad option in an older child, except for short-term relief. So what else could you try?
Could we try calcium channel blockers in this patient?
Well, you
I don't
can,
know.
but oftentimes, and I'll caution you with the beta blockers or calcium channel, if it doesn't work at low dose, I've had the experience of giving a beta blocker to someone with ectopic atrial tachycardia and ended up having very long pauses because all it really did was slow AV nodal conduction, but it did not really do much for the primary arrhythmia. It's not unreasonable to try it, and I have seen some success with it, at least in slowing the arrhythmia. But I would caution you that if it doesn't work at a low to moderate dose, going high dose usually will not be effective. Okay, so
Then Sotalol, I would go
right.
to Sotalol, yeah.
So the agents that you would use most commonly are either sotalol or flecainide or propafenone. Flecainide and propafenone are sort of the classic agents that are the most effective for this. And you have to remember that when you start a patient on either of those agents, it must be done in a monitored setting, such as a hospital on telemetry of some sort, because of the risk for pro-arrhythmia of these medications. So yes, you could put a patient like this on sotalol or on amiodarone. I'm sorry, or on flecainide.
Okay.
Amio, I would probably avoid if I could.
Okay.
All right. Okay, I got this tracing with a text a few weeks ago. The person who texted me said, "Morning, sorry to bother. Does this look like flutter to you? 20-year-old well girl with palpitations, chest pain, and was hypertensive." So why don't I ask Grace Kong what she thinks?
Good morning.
Grace.
So I definitely see P waves before each QRS. It's not so easy to see, but I do see them, and they're up in 1-2 and AVF. So there is presumably sinus rhythm. And given the text concern for flutter, I'm trying to look for a P wave in the interval that would give it 2-1 or 3-1.
Mm-hmm.
But I don't think I see, I do see the T waves that can fool me into looking like a P wave, but the interval wouldn't make sense for a flutter.
Right. So I agree with you, Grace. This is sinus rhythm. And I think that something about, as you said, about the T wave, it sort of gives you an undulating feeling like it might be some kind of atrial flutter here, but it is not. It's just sinus. You know, the key is you want to look and find a lead where you think you feel more confident that there's an obvious P wave. I think, quite frankly, in lead one, you could say that there's a P wave, then there's another P wave. It's pretty obviously clear sinus P wave, but because the baseline is varying, the relationship of the P wave and the T wave is sort of getting a little hard to see or is indistinct. But in a number of leads, you can convince yourself that there's a P wave preceding each QRS. So this is actually just a sinus rhythm. This patient was observed in the emergency room for a long time because of the elevated heart rate. So if you had a patient who was 145 beats per minute and truly did have a blood pressure of 150 over 100, how would you evaluate this patient? You've decided that the patient is in sinus rhythm. It's not an abnormal rhythm. It's not flutter. What would you do?
I could send thyroid. I could.
Right. Thyroid panel would be useful, although generally hyperthyroidism, I don't believe causes hypertension, but I guess it could. What else would you do?
Pheochromocytoma.
Right, pheochromocytoma. So you would want to send urinary catechols, or because you know, when you see somebody who's tachycardic, always, and it's you believe it's sinus, always that's in the differential. But you always want to see other evidence of high catechol, which would be high blood pressure. So this is a little worrisome. It turns out ultimately the heart rate sort of slowly came down. It never really came much below 100, but apparently this was a very anxious person, and the blood pressure also normalized over time. So I think it was ultimately believed that this patient was just anxious, nothing more than that. But that's probably what you would want to do. Okay. All right, let's move on. All righty. This is a newborn with WPW and Ebstein's anomaly who's being treated with amiodarone, and you're told the patient has a history of WPW, but doesn't obviously look that way. So I'm going to ask Perna Bonsall why it is, or what does she think is going on here?
Good morning, Dr. Paz.
Good morning, Perna.
I'm looking at the, give me just one moment.
Take your time.
I'm trying to see the P waves. So I think I see them most prominently in V1. I see a P wave before every QRS. So
Mhm.
P wave QRST, and then there is a deflection, and then again a P wave, which doesn't seem to be the same in every beat, but it's present in a lot of them. And then if I come back to lead 1, 2, 3, and AVF, so P wave is upright in 1, 2, it's sort of seems like it. 3, yes. AVF, yes. So it looks like sinus origin. Dr. Paz, is it like 2 to 1 flutter with, especially looking at V1, there are multiple P waves between, like 2 P waves between 2 QRS complexes?
No, I don't think so. I think if you look at AVF, right, I think it's
Yeah.
pretty obvious that there's just one P wave before every QRS. You know, again, when you start to think that you're seeing multiple, like in this lead, right, you could be fooled into thinking you're seeing 2 to 1, which is, I guess, what you're saying, or maybe in this lead. But if you look in another lead and it's more clear, then it seems unlikely that, or look down here on lead 2, it seems unlikely that one lead would be 2 to 1 and another single 1 to 1. So this is sinus rhythm.
Okay.
But how do you explain the fact that the patient has, you're told the patient has WPW? Does this look like somebody who has WPW to you?
I don't see delta waves here. PR interval looks normal in V1, in AVF. Yeah, P waves look normal. I'm not sure. Maybe it's not conducting through the accessory pathway.
Yeah, I mean, the point I'm just trying to drive home here is that this patient on amio, the amiodarone has blocked antegrade conduction through the accessory pathway. So the patient is not pre-excited, even though there is an accessory pathway. The only way you would know that is if you had another EKG from before the amiodarone. But sometimes, particularly with flecainide, you see this with people with WPW, but also with amiodarone. If you see pre-excitation go away after you've been on amio for a while, that's a good sign that there's a hefty dose of amiodarone, and it's unlikely you're going to have SVT, because presumably if you have antegrade block in the accessory pathway, you also hopefully have retrograde conduction block at the pathway. And so the patient is unlikely to have SVT. So this is a nice tracing of somebody who seems to be well treated with amiodarone for WPW. Okay. So this is a 1-day-old. And so my question is, what is this diagnosis, and how would you like to treat it? Why don't we go to David Barris, Barris and Associates, Can I ask
Good morning.
you, good morning. What do you think is going on here, David?
So I'm just looking at the two rhythm strips on the bottom here. We have what looks like wide complex, and in terms of our rate,
Yep.
looks about 1/5, a little bit more than 150. So it's not too tachycardic. So for
Right.
a 1-day-old,
Yep.
and then intermittent with these wide complexes, I see some, narrow complexes that look to be pretty much the same rate as the wide complex.
Mm-hmm.
So I'm trying to kind of figure out if we're having some aberrant conduction that then conducts normally.
Okay.
Let me see what else is going on in here.
I would point you to lead 3. There's an interesting observation here, I think.
So lead 3 has more of a maybe an RSR. Let me see
Well,
what
I'm
else
just
we're looking at.
I'm pointing to a P wave here.
So you're saying there's a P wave following the QRS complex.
But not every QRS complex, right? You notice this one looks different than this one or this one. I'm trying to suggest that there seems to be ventriculoatrial dissociation. Okay. So what do you think this rhythm is?
So it could be an either like an idiopathic ventricular rhythm.
Yeah. This is some kind of accelerated ventricular rhythm, or if you want to call it VT, you can call it VT. And the narrow beats are sinus capture beats. And you're correct, David, that the rate of the sinus beats, and you can only tell that from these 2 beats and these 2, are very similar to the VT beats, or the accelerated ventricular rhythm. And in the accelerated ventricular rhythm, there appears to be ventriculoatrial dissociation. And so this is an example of a so-called automatic arrhythmia. It's a form of VT, or accelerated ventricular rhythm, that you see in somebody, you can see in a newborn. And so baby looks well, it's completely hemodynamically stable. What would you like to do to treat this, David? Or do you need to treat this, David?
I would treat it.
Mm-hmm.
And I think we could use lidocaine since the baby is hemodynamically doing well.
Okay, so let's say we give lidocaine and it works. You're in sinus rhythm. So what are you going to do now? You turn off the lidocaine a day later, and you're back in this rhythm. So
We could use the lidocaine and also propranolol as well, and try to transition onto that.
right, so you could try a beta blocker to try and control this. You can really use virtually any antiarrhythmic agent other than maybe digoxin. So you could use a beta blocker. You could use amiodarone, the first choice of Uzo. You could use sotalol, flecainide even, although I wouldn't normally use flecainide for ventricular arrhythmia, but some do. And what would you tell the family? What's the natural history of this? You have a 1-day-old who has VT. Is there any other testing you would want to do about this patient?
I would want an echo on the patient. Perhaps lower yield would be electrolytes, just to make sure everything is.
Why would you want an echo? I'm in agreement with you, but what are you looking for?
So I think there could be like cardiomyopathy, either causing the ventricular arrhythmia, or as a result of the baby having been in a ventricular arrhythmia. So I'd want to evaluate for cause and also effect of the arrhythmia.
You have any idea where this arrhythmia is coming from? Can you tell from this EKG?
Maybe RVOT.
Yeah, it's RVOT, right? Because it's a left bundle morphology, and it's positive in the inferior lead. So it's coming in the direction from top to bottom and from the right ventricle. So This is an RV outflow VT. So what would you tell the family is the natural course of this? What should they expect? Is this child going to be chronically on medicines, you think, for this? Is it going to need an ablation? What's the scoop? So let's assume that the echo is normal and the baby is otherwise fine, and you're now on propranolol and you are reasonably well controlled, having rare PVCs, but basically in sinus rhythm most of the time. What are you going to tell the family? Is my baby going to need to be on this medicine indefinitely? What's the natural course of this, do you think?
I believe in a newborn that this will be outgrown.
That's right.
But I think that there's still a small possibility that they would need some sort of EP study in the future.
I think that the vast majority of these will resolve on their own, particularly when you're this young. As a general rule, the younger you are for almost any arrhythmia, the more likely it is that it's going to resolve on its own. It's not a hard and fast rule, but it's reasonably true. So you would give a very optimistic view of this because the chances are high that this is going to resolve with time. And so that's basically all I would say. It's a nice trace from one of our patients recently. Okay, this is an EKG that was sent to us, and the computer interpretation is sinus rhythm with marked sinus arrhythmia. And my question is, do you agree? Do you agree with the computer's interpretation? I think we will turn to Neha Alwalia, who I believe is in from Central Park at this point.
Yes, that's correct. Looking at the P wave morphology, the first beat looks upright in both 1 to AVF. However, the preceding beats have downward access to the P waves. So those are not sinus beats. So, and then there's pauses. So I would say that there is probably some ectopic focus with sinus beats. Is there sinus node dysfunction? Like, why are these ectopic beats coming in?
I don't know exactly, but it is unusual to have those beats. So, I mean, this patient could be a runner or something, have, high basal tone. So this is very similar, right, to the other tracing.
First one, yeah.
Right. I want you to feel like we're reviewing things and re-reviewing things. Very important to be able to use the data you just learned to inform new information, particularly for a catheterizer. So that's why I decided to ask you this question again. Right, so this is again sinus with an ectopic atrial focus, and just a nice tracing of that. So this is not sinus arrhythmia. And I've often explained to you guys that grouped beating, you should think about Wenckebach, but that is not what's happening here. So all group beating is not Wenckebach, but it should be in your differential. Now we know that ectopic atrial rhythms are also causes of group beating as well. So, okay. All right. This is a slow SVT that started to develop when placing catheters in the heart. And I am going to ask Dr. Perna Bonsall of Manhattan, New York, if she can give me an idea of what she thinks the mechanism is. So this is so early in placing catheters that we have neither an ablation catheter, a high RA, or any His catheter or RV. All we have is a coronary sinus catheter. So any thoughts on what the mechanism of this tachycardia is based on this tracing?
Looking at the surface EKG and correlating them with the coronary sinus tracing. So
And again, I'll remind you that this is SVT, although the cycle length is 450. So what does that make the heart rate for me?
I'll have to do the calculation. 60,000 divided by 450, 133.
Right. So very slow tachycardia, somewhat unusual.
So the coronary sinus, the ventricular, so the V's in coronary sinus are correlating with the QRS on the
Mhm.
surface EKG. And I'm trying to look if the A waves. I think it's earliest here in where you're pointing. It's earliest here in, I think, 3, 4, I would say.
Well,
Coronary sinus.
I think it's really, so these are the V, just like you said, and you analyzed this very well, Purna. Very intelligent to look at the surface ECG and go down in your mind's eye and say, well, anything that's simultaneous with the QRS is V. And that's what you said, and that's correct. So these are the ventricular electrograms. And then these are the retrograde atrial electrograms. And I think you would agree that if we look at the proximal CS, that A, which is in orange, is clearly later than the A in 7/8. You agree with that? That A.
I do.
And similarly, 5/6 seems to be starting at roughly the same time as 7/8. But then if you look at 3/4, unfortunately has a smaller atrial electrogram. And this is kind of a random thing based on the particular anatomy of the coronary sinus and where the catheter is sitting. But I think you could argue that that's the retrograde A there. And then the A in the coronary sinus distal pair is way out here. So it looks to me like the earliest retrograde A is in the 7/8 or 5/6 pairs. And this is what we would call bracketing, meaning that we have a pair that is later than the earliest on above, proximal and distal to the area where the pathway is located. And that's nice for the electrophysiologist because it means you don't have to go any further proximal on the where you're mapping than the CS proximal, or as far out distal as the coronary sinus distal pair. So where would this pathway be located, you think?
Near the opening of the coronary sinus.
Well, it would be near 5/6 or 7/8, right? And we don't know how
Yeah.
far I've gotten the catheter out into the coronary sinus. In this particular case, the catheter was pretty far out in the coronary sinus. So this would be on the left side, and this would be some kind of a left-sided accessory pathway, right? But it's a little unusual that the tachycardia rate is so slow. But that's life. Sometimes things aren't as we expect. So in the end, it turned out that this was a left-sided accessory pathway, which we ultimately successfully avoided via a transeptal approach. So it's interesting, when you're starting an EP case, even at the very beginning, when you've just placing the catheters and you have one catheter in place, immediately within the first minutes of the case, you can make a diagnosis. So it's not uncommon that just the first couple of beats when we have catheters in place allow us to know what we're dealing with when we did not know before. Okay, this is a 12-year-old following mitral valve replacement, and backup pacemaker is set at 52 beats per minute. I do not know why at that strange rate. And my question to you is, what is wrong here? So why don't I ask Dr. Uzoma Obiaka. So Uzo, you're in the ICU in your new job as a cardiac intensivist, and this happened. Someone was nice enough to put this little unclear red asterisks on this slide. This is a slide, by the way, from an EP conference I gave 17 years ago. Just as important today as it was then.
Okay.
When you were probably in elementary school. This
So
could have been you, so. God forbid.
so looking at the tracing, so the first the first few beats
Mhm.
seem appropriate. So they seem like sinus beats, which rates slightly less than 100. So maybe I'll see like maybe 80 to 90.
Mhm.
So we have the first, second, third beats, and then there's a pacing spike,
Mhm.
and then we see that there's V pacing there, and then the next beat seems appropriate as well. So that seems to be like so it seems to be like an inappropriate pacing spike.
Now, why is this appropriate or inappropriate, this beat here, do you think?
So we I already saw that this patient's intrinsic rates seem to be about 80, and
Right,
we haven't let it get to that, and there's already pacing. It's already pacing.
right. So what would this be? This is pacing at a rate faster than
Than the
52
pace,
beats per
yeah,
minute.
than the backup,
This
yeah, than the backup.
bizarre pacing rate. So if that is in fact the case, what does that mean about the pacemaker and what's wrong with it?
It means that it's sensing inappropriately.
Right, it's undersensing. It thinks that it must not have sensed this QRS, or I don't know, somehow it's sensing improperly because it thinks it needs to pace here. Similarly, this speed also, right?
Yeah,
Is at
it
a
also
rate of like
pace.
150 from the last
Yeah.
QRS, and yet it's pacing. And then what
then
happens
we
here?
go, and then we pace. We have an appropriate beats, and then again it paces, but then it paces on the T wave, and so we've tipped the patient into some ventricular. This looks like VFib to me.
Yes,
So it seems like we've tipped the patient into
this
VFib.
is the big risk about undersensing, is that you can pace in the wrong part of the complex. And in this case, the patient has been paced into ventricular fibrillation because of an R on T phenomenon. So this is a very dangerous and very rare, thankfully, but very worrisome finding. So this happens. What would you do, immediately?
So this happens, I would cardiovert the patient.
Well, you would defibrillate
I
the
would defibrillate.
yeah.
Sorry, it's
So
unsynchronized.
you would
I
not
would
synchronize. And
I would-
how many joules per kilo? Let's say the patient is 50 kilos. How many joules would you give the patient?
I'll give the patient 100.
That's right. That's very important. When you're dealing with a ventricular arrhythmia, give 2 joules per kilo. I have seen this mistake made because people are afraid to give the right amount of energy, or they don't want to give a lot. It's scary on your own to defibrillate or cardiovert somebody, but you have to remember, for ventricular arrhythmia, you want to give 2 joules per kilo. So yes, you would give 2 joules per kilo unsynchronized. Let's say it doesn't work. What would you next do?
I would repeat at a higher dose. So
That's
I would
right. I would give
I would
4
do maybe
joules per
one-
kilo,
okay.
double it.
Yeah.
Because you got to get this patient out of this. And if that failed, then you would start doing CPR and following PALS, and that would involve giving amiodarone and trying again. So exactly. So the way you would acutely and chronically manage is, of course, to adjust the sensitivity
Sensitivity.
on this pacemaker and figure out why it is not sensing properly. And this, by the way, is one of the reasons why you have probably all noticed that when I'm on service, I often am asking them to turn off these so-called backup pacemakers. Oftentimes, I notice that a lot of post-op patients with temporary wires, somebody has decided that we're going to leave it like VVI backup at 50 beats per minute or at 70 beats per minute or something like that. There's nothing wrong with that, but the problem with it is that it assumes that the sensing is going to be perfect all the time. And the problem is that temporary wires, by definition, don't sense as well as permanent wires. And every once in a rare while, something like this occurs. And this is completely unnecessary, particularly if you had a patient who was, I mean, I assume this patient in this example recently had surgery because they still have a pulmonary artery catheter in place. And usually you would pull that out on post-op day 1 or 2. But the point I'm trying to make is, that this is an example of just an iatrogenic problem related to undersensing of a temporary pacemaker. And so I would caution you, obviously, if you're worried about bradycardia, it's not wrong to have it on, but if you have a patient who's 2 or 3 days after surgery has had no conduction problems, it's not unreasonable to leave the pacemaker attached to the wires, but I'm not sure I would leave it in a sensing mode, because every once in a very rare while, something like this will occur. And when it happens, it's very frightening. So I think with that, we'll stop. You guys did very well. These were very challenging cases today. And I will see you in conference in just a few minutes. Have a great day, everybody. Thank you.
Thank you.
Thank you.
Thank you.
Thank you,
Thank
Dr.
you.
Nash.